Hello, everyone. I'm back, and in this set of video lectures, or this video lecture, I'll see if it fits into one. We're going to talk about coding and reimbursement. Coding is inherently tied to hospital outpatient reimbursement as well, but the importance of correct coding really comes into play with hospital reimbursement. We'll cover the hospital reimbursement with the MSDRG reimbursement model. We'll talk about prospective payment and other topics. Let's have a look. Okay, again, this chapter doesn't have any codes, doesn't have any chapters, doesn't have any guidelines. Here's what it does have. It covers coding and reimbursement, particularly in regards to hospital reimbursement. The largest payer of healthcare services in the United States, and for that matter, the world, is Medicare. Medicare is split into Medicare Part A, which is an entitlement that covers hospital, Part B, outpatient services, and Part C, which is Medicare managed care, and then Part D, which is relatively recent, which is pharmaceuticals. We're going to focus this chapter on hospital reimbursements. As part of the effort to balance federal spending, we now have hospitals on what we call the MSDRGs. This stands for Medicare Severity DRGs, or diagnosis related groups. How these MSDRGs are created is we take a principal diagnosis and procedure, and they become a grouping of like diseases. You can only have one MSDRG for each hospital admission. We had DRGs getting introduced in the hospital reimbursements setting for Medicare since the 1980s. But as time went on, we realized that there were inequities in it. So within a disease grouping, we had some people that didn't take as much resources as other patients. And so there were different levels of severity. So some admissions were perhaps paid more, some admissions within the same DRG were paid less. So in an effort to kind of balance this out, we came up with the idea of Medicare severity. So an MSDRG with a major complication or comorbidity, or as is abbreviated, MCC, is the sickest and the most resource intensive of the MSDRGs. MSDRGs with just a complication or comorbidity that's mid-level get less, and MSDRGs with no complications or comorbidity, which don't really affect the severity of the illness, get the least of the same MSDRG. Let's take a look at your text where they get into this in a much finer level of detail than the slides. Here's an example of the MSDRG for heart failure. We have the MSDRG, heart failure and shock. Then we have a secondary diagnosis of pneumonia, as you can see here. The pneumonia is the major comorbidity complication. So we have the MSDRG of 291. The principal diagnosis is heart failure and shock, the pneumonia. And then, as we mentioned, the pneumonia is the MCC. MSDRG 292, heart failure and shock. The secondary diagnosis is primary pulmonary hypertension. This is the comorbidity complication. Then finally, we have heart failure and shock, MSDRG 293. and type 2 diabetes, and that's not considered a complication or an MCC, a major complication. What drives the MSDRG is the diagnosis and the procedures that are coded. The principal diagnosis, which you can only have one of, and 24 additional diagnoses, secondary diagnoses, for a total of 25. You can have up to 25 procedures. Then you need the discharge status, which would be where the patient is discharged to, which is part of the UHDDS that we talked about earlier. And then whether the secondary diagnoses are considered an MCC or a CC. The way it works in terms of reimbursement for the hospital, this could be a college course in and of itself, but each MSDRG has a relative weight. Each hospital has an individual payment rate, and the hospital payment is determined by the MSDRG weight multiplied by the hospital base rate, which equals the hospital payment. In addition to the basic payment, Medicare will allow for additional payment. This includes such things as disproportionate share hospitals. You get an adjustment for that. Hospitals with residents and fellows get indirect medical education adjustments. So you get a little bit more for that. Hospitals that use new technologies or medical services that are approved special add-on codes will have additional payments for that. For example, a relatively recent example of this was the mitral valve clip, which came out for patients with mitral valve prolapse. Instead of having heart surgery, hospitals that were undergoing this would actually get a little bit more for that. Then finally, discharge disposition and outlier payments. You can think of outlier payments as those specific cases that fall out the norm of an MSDRG. So there were additional adjustments for that. Some categories of hospitals are paid higher, the higher of either a hospital-specific rate based on their costs in a base year. These hospitals get this additional payment in order to protect their financial viability because they provide critical access to underserved hospitals. Some examples of that would be sole community hospitals or Medicare-dependent small rural hospitals. So in those areas that are outside of a major metropolitan area, this is a way of ensuring that these hospitals can financially survive. So again, the important things that you need to know: MSDRGs are divided into major diagnostic categories. What these are groupings of diseases. And one of the things that determines that is the coding. The coding specifically, a very important part, is the ICD-10-CM principal diagnosis code. That largely determines what major diagnostic category the hospitalization will fall into. A reference for this would be the coding clinic and coding guidelines as tools to remain current with the MSDRG system. Any changes to the MSDRG system is published in the Federal Register, and these would include such updates on complications, comorbidities, MCCs, and other things that have an impact on MSDRG assignment. Conditions that are present on admission do get reviewed. One of the things that we saw recently was patients that are admitted to the hospital from a nursing home often would have skin ulcers. This is a comorbidity, or it could be a complication if it happened after the patient was admitted. CMS, or the Centers for Medicare and Medicaid Services, does not want to pay additional resources for that. So now what we do is we flag these on admission to say whether the condition was pre-existing or whether it developed after admission. The inpatient indicator that's reported with each final diagnosis code says whether a condition was present on admission. And there can be 4 choices: either yes, it was, no, as in no, it was not, insufficient documentation, or clinically undetermined. Comprehensive present on admission guidelines are included in the official guidelines for coding and reporting. Any claim that involves an inpatient admission must have a collection of present on admission. Present on admission means that it is present at the time of the inpatient admission. This is any condition that develops during an outpatient encounter. For example, the ED, the emergency department. Present on admission gets assigned to the principal and secondary diagnosis and the external cause of injury codes. Anything that's inconsistent or unclear about whether a condition was present on admission or not must be resolved by the provider. In other words, we need to query or ask the provider whether the condition was clearly present on admission or if they couldn't determine what it was. A condition that is not present on admission but manifests during the hospital is considered hospital acquired, or HAC. These are considered preventable by CMS. So as a result, any resources that are used by the hospital to treat something that developed after admission is not going to be reimbursed. Another adjustment that happens for MSDRG payments includes when excess readmissions are identified. The MSDRG system has the hospital measure their case mix. What the case mix is a measure of resource consumption or the cost of providing care. This means that we pick up the severity of illness, and that's included on the hospital's case mix. Reimbursement is only going to be provided for services that meet the criteria of medical necessity, a term you hear often in hospital reimbursement. Value-based purchasing adjustments is rewarding acute care hospitals with incentive payments for better quality care. Hospitals can earn scores one of 2 ways: how well they perform compared to all hospitals, and how much they improve their own performance. The incentive adjustments are paid on a claim-by-claim basis, with the adjustment factor based on the hospital's total performance. And some of the scoring includes such items as mortality and complications, healthcare-associated infections, patient safety, patient experience in terms of patient surveys, efficiency, and also cost reduction. Medicare review programs have reviewers, and these can go a couple of different ways. They review a certain percentage of inpatient prospective payments and long-term care hospital records for payment services. In other words, seeing if they're being billed appropriately. And then CMS also contracts with Medicare Administrative Contractors, or the MACs, to conduct medical and coding reviews to see if the documentation supports the claim and therefore the MSDRG. Medicare coding reviews are an important part of the quality improvement organizations. We use these to improve quality care. This protects the integrity of the Medicare Trust Fund by ensuring that Medicare is only paying for services that are reasonable and necessary. These protect beneficiaries with performed expedited coverage reviews for appeals or request. Quality improvement organizations perform medical review services, and these review the beneficiaries' and appeals in response to a provider-based notices, and also review any allegations or violations of EMTALA, EMTALA being the Emergency Medical Transfer Liability Act. Basically, this is the law that says that if somebody is critically ill, sent to the emergency room, hospitals are obligated to at least triage them, assess, and treat them if they can't be transferred. So that's what the quality improvement organizations do. And the way they review these is by pulling data based on the codes. Medicare administrative contractors process the medical claims for beneficiaries. They're essentially the middlemen between the federal government and the hospitals. These are companies like Lumetra, Palmetto, some of the other ones you may have heard from. These are the ones who make the payments directly to the providers for Part B and to the hospital for the MSDRGs. They enroll physicians and others into Medicare fee-for-service programs, and they basically handle all the reimbursement issues. They do their own audits, respond to providers' questions, and educate providers about Medicare fee-for-service billing requirements. These Medicare administrative contractors have a couple of things that you've probably heard from before. The beneficiary notice, and also the local coverage determination policies. These determine whether an outpatient encounter is reasonable and necessary for the Medicare beneficiary, in other words, the patient's medical condition. Medical records are reviewed on selective claims for coding, billing, and medical necessity requirements. The CERT contractor reviews, in other words, the comprehensive error rate testing, measure the payment error rates for acute care hospitals and long-term care hospitals. These reviews are done retrospectively on a post-payment basis, and the hospitals are asked to provide copies of selected records to the CERT contractor. A relatively new area is the recovery audit contractors. These are essentially a collection agency. So what they do is they review medical records with Medicare claims to detect any overpayment. That's basically what they do. And some of the things that they find are incorrect payment amounts calculated by the insurer, non-covered services paid, incorrectly coded service that results in a wrong principal diagnosis or principal procedure, or major comorbidity being miscoded, which alters the MSDRG. And then the other thing that frequently we see are duplicate services being put on a claim form, billed, and paid. When a provider is notified of a denial, the provider has an appeal process that's listed in 5 steps. They can discuss with the Medicare administrative contractor. That doesn't get resolved, it goes to a qualified independent contractor. Thirdly, it can be forwarded to an administrative law judge. That doesn't work out, it goes to a Medicare Appeals Council, and then it goes for judicial review all the way up to and including the federal district court review. Here's something of interest to those of us who work with coding and reimbursement. 74% of all the improper payments are for medically unnecessary services that were submitted for and paid. The other one is 12.2%. So in other words, we have insufficient documentation to justify the payment. Many of these are based on incorrect coding. We also can have underpayment due to incorrect coding of 7.1%, 5.1% due to incorrect coding, and then no documentation to justify the payment. And these RAC auditors are responsible for 1/4 of the country to review providers. And this area will continue to grow with our aging population. There'll be more of an emphasis on these recovery audited contractors. We've talked about medical necessity. Basically, the premise of medical necessity is this service, this admission, this procedure, reasonable and necessary to treat the patient? And there are three things that we look at when we talk about medical necessity. First of all, what's the likelihood that this service will have a reasonable beneficial effect on the patient's physical condition and quality of life? Secondly, are we using healthcare services and supplies that are proven and acknowledged to be effective? And thirdly, is the procedure performed for a specific diagnosis or frequency? So in other words, is this necessary? Accurate coding is essential to establish the medical necessity of a service. And this happens on both a national coverage determination from CMS and local coverage determination as per the Medicare administrative contractor. The MACs developed the local coverage decisions to define what medical necessity is. The national coverage determination defines the medical necessity. Physician documentation must have the reasons why a diagnostic or therapeutic service is coded for billing. We don't just do tests to do them. They need to be mapped or related to ruling out or ruling in a specific diagnosis. The beneficiary notice, the advanced beneficiary notice, it says here, is a statement signed by the patient when he's notified by the provider prior to his service being performed that Medicare may not reimburse the provider, whereupon the patient indicates he will be responsible for any charges. So it's basically saying, if Medicare doesn't pay, you're going to pay. The OIG work plan talks about how we're financing Medicare. And there's some new developments on it that include such things as accountable care organizations, which is basically going across the continuum of care to both improve quality and reduce cost. And this has led to other things along this line, such as the Medicare Shared Savings Program, Advanced Payment Accountable Care Model, and the Pioneer Accountable Care Organization model. That's all I have for you. We'll see you online.